series of lectures on key topics related to treatment of opioid use disorders in hospitals that we're offering. I'm Jennifer McNeely, and we're going to be led through the presentation today again by Shane Gallagher, who's the lead trainer for this project. And I'll let Shane introduce himself next. We are offering CME credits, and Aditayo, do you want to give any details about CME now or later?
Yes, CME information will be given at the end of the lecture. Thank you.
Great. And I see folks putting name, hospital, and email into the chat. So thank you very much. Please keep doing that so that we know who's here and we can follow up. And we will also let everybody know how to access the recording once we post it after the lecture. And with that, I'm going to turn it over to Shane.
Hello, everybody. For those of you who I haven't met or seen before, I'm Shane Gallagher. I'm a psychiatric nurse practitioner at Bellevue Hospital. I was part of the Catch addiction consult service for the past couple of years. I've now transitioned into a role practicing clinically in inpatient psychiatry, and then at NYU, both as a researcher and an outpatient clinician in the addictions area. And so today we're going to talk about the diagnosis of opioid use disorder in hospitalized patients. And so just to remind folks, if you haven't already, please type your name, the facility, and your role or position in the chat box. We'll take attendance to later award CME credits. If possible, if you could please turn on your video. We understand it's lunchtime, so if you're eating, that's fine. Please mute your mic when you're not speaking. Change your name so that we know who you are. We're going to have some discussion prompts, so please just give us your name and facility when you chime in. Remember to keep it confidential with no identifying information. We're all figuring this out together. So there are no stupid questions. Some of this material may be familiar to you, but we're going to throw in some new points to talk about some of the nuances of discussing diagnosing patients in the hospital. And it's an all teach, all learn model. So please contribute some of them. Some of the questions or discussion points will ask you to share case examples or some of your experience, and we'd love to hear that. It's always helpful to hear on the ground how things are going at different hospital sites and so forth. So the two major topics, first we're going to talk about how to diagnose a substance use disorder using the DSM-5, and then identify some potential differences. What are some of the differential diagnoses for patients who are using opioid, who meet the criteria for opioid use disorder, or if they're more have like a risky use, or if they're prescribed the medication, perhaps they're misusing it. They have a prescription for chronic pain, but they're not using it as directed. So we'll talk about some of the nuances, the tools, and then how to approach that. Some acknowledgments on folks who helped prep the slides there. And so this is just a kind of refresher that picking up from our last talk, and how we see this kind of three-wave model starting in the early 2000s leading up to today. And when synthetic opioids such as fentanyl and synthetic fentanyl were introduced to the supply, we saw a major increase in the deaths. So yeah, this is why we certainly want to be screening and rendering a proper diagnosis, both for epidemiologic purposes and also clinical purposes, so that we're making the appropriate referrals. So first question, how do you define addiction? Please feel free to either jump in or put in the chat box, whichever. brave souls. All right, so we'll throw another question in the mix there. And you can feel free to answer. Oh, okay, we got some. Thank you for those brave folks. Use of a substance to the point of adverse effects or physical dependence. Yep. Any substance or behavior that makes your life unmanageable. I like that one, the kind of functional impairment. Building on that, what is your experience with diagnosing OUD in your clinical setting? Do you see it? Do you feel like it's underdiagnosed, misdiagnosed? Another nuance I see in the chat, a complex neurobiological phenomenon. That's a great point as well. Biobehavioral disorder. All right, well, thanks for those contributions. Appreciate it. We'll throw out some of the formal definitions. So the American Society of Addiction Medicine, I have a link there. Addiction is a treatable chronic medical disease involving complex interactions among brain circuitry. So the classic VTA to NA, the ventral tegmental area, the nucleus accumbens, the areas associated with reward, motivation, and memory. Genetics, the environment, and an individual's life experiences. So people with addiction use substances or engage in behaviors that become compulsive and often despite harmful consequences. So that, as someone had just mentioned about when despite adverse effects and making life unmanageable. So we got spot on there. Prevention efforts and treatment approaches for addiction are generally successful as those for chronic diseases. So we talked about this last time, that it really should be the standard of care to offer all folks with OUD treatment because it lowers the mortality rate almost to that of the general population with no treatment. Addictions characterized by inability to consistently abstain, impairment in behavioral control, cravings, diminished recognition of significant problems with one behaviors and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction often cycles with relapse and remission. And so as we go through the slides, we'll talk about, this is kind of something to communicate to your patients. In the outpatient setting I work in, patients often won't feel comfortable or initially feel a lot of guilt and shame, even leading them to not want to come to their appointments if they relapse. So focusing on, as another disease, you may have a period of remission, but relapse is part of the cycle to be expected. That's something I kind of focus in on, and how to, just best mitigate risk and harm from that point. Without treatment or engagement in recovery activities, addiction is progressive. As we know, it can change the neurobiologic architecture of the brain and can result in disability or premature death. And to review there, as we said, it's compulsive behavior despite adverse consequences. And then Maya Salovitz, addiction from a behavioral standpoint is difficulty learning from punishment. So despite these adverse or negative consequences, continued use there. And so evaluation, we're going to use a framework adapted from the ASAM National Practice Guidelines. We're going to evaluate the frequency and quantity of current and past use of drugs. So when you're taking a drug history, you want to kind of ask, you start with their opioid use, but you also want to be asking them about cocaine use, smoking cannabis, cigarettes, alcohol, misuse of benzodiazepines, stimulants, or other illicit drugs, as well as non-medical use of other prescription medications. And then the key pieces you want to focus in on, the type and amount of opioids used recently. So sometimes I will ask folks, have you used any opioids? And they'll say no, but then when you expand, when you say this includes heroin, fentanyl, any type of pills, oxycodone, they will say, oh yeah. So it is helpful to just kind of give them some examples. The route of administration is definitely important. You want to be asking if they're using intranasally or intravenously, and then think about some of the associated risks and some of their behaviors when they're using IV, how you can provide some harm reduction interventions there. You always want to ask folks their last use, and I'll also add in there it's informative to ask them their first use, what kind of led them to that, because it can give you some ideas about how to frame the treatment. If it was like a group or friend or familial circle that introduced it to them, it may be helpful to refer them to rehab or somewhere long-term detox where they can kind of get themselves out of that environment. Or you may have folks who initially were given a prescription for chronic pain, and when they ran out of that, that led to misuse. So that can kind of inform that you may need to optimize their regimen to still treat that pain, but it gives you some ideas of how they have some, predisposition to addiction. You also want to discuss their treatment history, so both psychosocial. So I always ask folks, have you ever been to detox, any rehabs, any long terms? And when I'm screening about opioids, you ask them about overdoses. Like we said, are they using intravenously? Um, and then any medication trials. So have they tried any of the medications available for OUDs or MOUD, such as Suboxone, Methadone, or naltrexone? And then problems resulting from drug use. So I ask if they've ever been hospitalized, if they've had overdoses, if they've had any type of complications from use, if they've been encountered the legal system or had legal troubles because of use. And so we'll go over some of the DSM criteria, so some of the questions that you should be asking to render a diagnosis of OUD. So in the previous edition, the DSM-4, they separated substance use disorders into two categories. There was substance abuse and substance dependence. And so the dividing line between these two wasn't all that clear, and there would often be a confusion with substance dependence and physical dependence. And so in the DSM-5, there's a single term. There's SUDs, or substance use disorders, and the major changes are recurrent legal problems was a criterion for substance abuse was removed. And a new criterion was added, so craving or strong desire, urge to use. And so it's important to be assessing for cravings both on initial assessment, but then on interval as well, because that can be, your decision pathway for how you up titrate methadone or Suboxone. If you max someone out on a dose of 24 of Suboxone, or if you get up to the standard blocking dose of 80 milligrams of methadone, sometimes folks still have significant cravings. They'll say that they used above it or they missed it. They've been thinking about it a lot. So that's something you want to talk about. There are some standardized craving scales that you can use. But so the first, they have them in different categorical clusters. The first one is impaired control. And so taking more or for longer than intended. And so I usually, when I ask people about their use, I say, how much have you been using on a daily basis in the past week? And if they say they're using heroin, if they say between 5 and 10 bags, I'll ask them, do you find it hard to stop? Once you start, once you use a bag or two, do you find that it's hard to stop? And that can be an indicator of a more, severe OUD, because the person will say, they bought what they'll say a bundle, 10 bags, intending to stop, but then they ended up spending, double, triple the money, and will say they were using the entire day. And this maps onto as well not being able to cut down or stop, and they've had repeated failed attempts to do so. Spending a lot of time obtaining, using, or recovering from use. And so this is the cycle I was saying, some folks who say they use a significant amount of the day, then they often will talk about the anxiety or anticipation of withdrawal and how it usually will be the first thing that they think about when they wake up. How are they going to get their next access to opioids to be able to prevent withdrawal? So the second cluster, or the second two clusters we'll see is social consequences and risks. Um, so role failure, and so this is kind of indicative of the DSM as a whole. So if it's causing significant impairment in social or occupational functioning, this is how the DSM kind of conceptualizes disorder. So if it's interfering with homework, school, or familial or caretaker obligations, they keep using despite relationship problems that are caused or exacerbated by continued use. Important activities, hobbies are given up or reduced because of use. And then risky use, so recurrent use in situations that are hazardous, and keep using despite physical or physiological problems. And so for folks who are working in the inpatient setting, often by virtue of their admission, they'll meet criteria for not there, that they're having say cellulitis or infections related to IV use and now are admitted. And the last is so pharmacologic and physical dependence. The reason these are asterisks is because these criteria in and of themselves would not be reason to render the diagnosis of opioid use disorder, because two criteria can give you the diagnosis. But these can be, as we know, tolerance and withdrawal are kind of the physical phenomenon, and they alone would not be sufficient for an OUD diagnosis. So we'll talk about severity index. So again, these are the craving and compulsion cluster here. And then the second group, 5 through 9, are consequences and loss of control. And then, you know, this is just important to think about if you have a patient who is on chronic or long-term opioid use, they would have to be tapered like anyone else to prevent withdrawal, because by virtue they're going to have tolerance. Their opioid system is being upregulated, so they're going to have higher receptor saturation and occupancy. So something to just keep in mind. And so to this point, if taken long enough, everyone would develop some level of opioid tolerance, and this could be as short as 5 to 10 days for some folks. And this is when you need higher or more frequent dosing to achieve the same effect. And then physical dependence is characterized by withdrawal syndrome when they're stopped, missed, or tapered. And here are some of the objective symptoms there: dilated pupils, piloerection, diaphoresis, pain, diarrhea. These are all captured in the cows. When inpatient, for those of you who are inpatient folks, what I usually will tell nursing staff or staff who are training at assessing opioid withdrawal, it's important to focus on the more objective signs. So these are some good examples of kind of bona fide opioid withdrawal. Because in the early phases, say if you're planning a Suboxone induction, it's pretty common for the patient to have increased anxiety and restlessness. So it's good to look for some of the more objective signs here. And then when you're classifying severity, 2 to 3 symptoms is mild, 4 to 5 moderate, and then 6 or more would be severe. So a note on stigma. There's research, the University of Pennsylvania group has examined the negative impact of addiction-related jargon on treatment-seeking behaviors in patients. And so in a sample and one of their studies, 18%, they found that 18% of patients they screen that meet criteria for a substance use disorder actually seek treatment. And of those who didn't receive treatment yet reported perceived need, 28% of them cited stigma as the reason for accessing care. And in qualitative analysis, they found that words that would elicit a negative implicit bias where substance abuser, addict, alcoholic, and relapse. Um, so it's just something to think about. Folks in the field definitely move away, even though patients often will self-identify. Um, I see patients frequently who say, "I'm an addict" or "I'm a junkie." I like to kind of reframe their thinking and say that they're a patient with a disorder or a person with a disease. And same with colleagues as well. It helps um, to prompt, that using these words can be stigmatizing or have the make it more difficult for a team to build rapport. Um, Similarly, when I have patients on BUP who come in, they'll often say my urine is dirty, and the same deal with when I was talking about guilt and shame. They'll often say I'm really embarrassed or I'm so ashamed that my urine is dirty, and so I like to just say to them. It doesn't mean you as a person clean or dirty. We're just we have a positive test. This often comes up with family members and friends. Um, a lot of folks may have heard ORT, opioid replacement therapy, before we used MAT, and so this concept comes up a lot. The phenomenon of substituting one drug for another, or trading one addiction for another. So that's something to kind of explore if a patient is reluctant to um, start a medication. Kind of just talk about what are their concerns, um, and I usually will highlight that since so much of the supply is tainted with fentanyl, um, in my clinic we test for fentanyl in the urine, and I find quite often I'll review those results with patients, and they're quite surprised and concerned. So kind of reorienting them to taking a safe medication that's FDA approved that we can monitor and control their cravings, that it's like treating any other disease. And often in um, in medical settings, I find the term drug seeking gets used a lot, and it can often have a negative connotation, even if the patient has real pain or you see the patient with active withdrawal symptoms. Folks will kind of prematurely label patients as drug seeking, and this I find often um, will motivate clinicians to want, or whether consciously or subconsciously, end up under medicating the patients because they're worried about what if I'm feeding into this? What if I make an addiction worse? So I usually will work with teams um, that if you have an acute situation where a patient's in visible pain, or we're concerned about a patient leaving AMA because their withdrawal is undertreated, um, there's not as much concern about making their addiction worse. There's more fear about undertreating. So I'm curious, what words have you heard in your workplace or hospital setting, perhaps in the news media? Do you have any experiences with patients feeling stigma or communicating feeling stigmatized to you? Sure, there has to be some stigma out there. I can't be the only one who's heard it. So someone put patients often refer themselves, "I'm an addict." Yeah, and I talk to folks sometimes too, because sometimes that's part of recovery groups. Um, so I do talk about them. Um, it's important to recognize the symptoms and how it's impairing their functional status, but it doesn't have to be their identity. They don't have to kind of that there's so many more elements to them as a person. They don't have to kind of feel that. Someone shared about a postpartum patient who had a surgical complication eating pain meds on Suboxone. Um, family was hearing staff calling her drug seeking. Um, people are also saying they often hear drug seeking patient. Um, yeah, it's out there. Um, additional components of the evaluation. um, you want to ask them in their history concomitant medical conditions. So have they been screened or treated for Hep C, HIV, TB, acute trauma, or IV drug use related infections? And this can be a good opportunity to discuss with them about a needle etiquette and where to obtain clean needles or fentanyl test kits. Um, certainly, you want to talk about co-occurring substance use disorders. Often, I'll find that um, the use, if they're using multiple substances or have a polysubstance picture, there's often influence in using one drug and another. And like for example, a patient that I'm seeing was interested in going on to Vivitrol. Originally was on Suboxone, but was interested in Vivitrol because when he was on it, it made his cravings for alcohol much less. Often was hanging out with folks who were using opioids and said if he was, had a few drinks, when people would offer it to him, it would be much more likely that he would accept it. So that's something to just explore and ask them, do they see? Uh, alternatively, some folks. I have a patient on Suboxone, and now we're kind of trying to address as he's stopped using opioids, stopped using heroin. Now he smokes marijuana much more, so we kind of talk about how these can kind of co-vary with each other. Um, psychiatric history very important. Often, if a person has, say, a mood disorder, if it's untreated, if they are getting really depressed or anxious, this is often what's driving their use. They often will start initially using to kind of self-medicate these symptoms, and so it's definitely worth referring to a psychiatry program, dual diagnosis, or chemical dependence program if you have access, because they can kind of address how these symptoms kind of contribute to one another. Similarly, a lot of drugs will um, mimic a psychotic episode. So a lot of the patients that I see in clinic have misdiagnoses of psychotic disorders because they presented many times psychotic to the ED. But when there's a period of abstinence, they don't have any psychotic symptoms. Always important to be monitoring iStop or your PMP program. Discuss nicotine use, and then the psychosocial and environmental factors. Patients who are in 12-step programs frequently use the term people, place, and things. It's something that I hear a lot now, and I will sometimes say if a patient's kind of hitting an obstacle in treatment and they're finding it hard to kind of cease that, they're reduced their use and they want to completely abstain, but they're having kind of some trouble. Often, if you discuss what their environment is like, what their kind of daily routine is like, who they're around, it's often the case that that's kind of what's driving. There's a lot of stimulus control in their behavior, so it's something worth discussing. And then in the physical exam, signs of intoxication, acute intoxication. So opioids, drowsiness, decreased respiration, and then withdrawal, like we were discussing, you want to use the cows. And then signs of trauma or liver, heart, infectious diseases, cutaneous stigmata or IV marks, and then some lab screening that you want to do, a CBC, liver function test, TB screening, Hep B and C panels if they're using intravenously. And then in terms of drug testing, a lot of times in the urine drug screen, like the common 5 panel, it's worth just asking if there's someone who's more familiar with the toxicology capability in your facility, what drugs may not be showing up. I know in some like benzo urine panels, for example, it won't pick up Klonopin. A lot of opioid urine panels don't specifically test for buprenorphine. Some facilities you have to send it out, so it's a send out urine. So it's just important to know you may have a patient who is negative for opioids in the urine, but are indeed adherent with their outpatient Suboxone. And so, in summary, you want to be using the DSM criteria for diagnosing opioid use disorder. Um, and here, language matters. It's very impactful. So, a case example for folks to ponder: 54-year-old woman with chronic pain for inflammatory arthritis presents to the ER stating she's out of her OxyContin, oxycodone, and is having a acute flare of her arthritis. She knows it's too early for prescriptions to be filled, but she's traveling out of state and really needs her medications to get through the day. It's Saturday, her clinic's closed, and primary care provider's on vacation, and she's about a week early for refills when you check iStop. So, discussion question: how do you approach this patient in the ER? And more info: what if she was one of your chronic patients? You knew she had very legitimate pain, um, inflammatory arthritis, severe osteo, knee replacements, hip fracture, but also has a comorbid alcohol use disorder, previous DUI, spouse is concerned about drinking, and there was previous hospital visit and knee arm injury from a fall due to mixing pills with her drinks. How would you approach this patient in the ER?
And anyone is welcome to take themselves off mute too if you rather speak how you would handle the situation. Any ideas?
Complex case here, a lot going on between uh, potential misuse of prescription opioids and drinking. So we'll look at an overview of chronic non-cancer pain. Quite common subjective sensory and emotional experience, significant cost burden to healthcare and society, and it's quite prevalent in those with opiate use disorder. And so you want to kind of parse out the pain and discomfort associated with withdrawal itself versus the primary pain syndrome, because there is this physical dependence to opioids. And so here there's some stats on substance use and chronic pain. And so it's estimated about up to about 32% of chronic pain patients may have an addictive disorder. 56% of people over age 20 reported pain that lasted more than 3 months. 36% had disabling pain in the past year. 57% of people over 65 had pain that lasted more than a year. 5% of U.S. residents age 12 and over report non-medical use of pain relievers. 19% of people over 12 report they initiated illegal drug use with pain relievers. And anywhere from 30 to 60% of patients with opioid use disorder report chronic pain. So quite sobering numbers there, quite prevalent issue. And so in managing chronic pain with folks who are in recovery or from a substance use disorder, SAMHSA has these tips. This is tip 54. And so this activity can be, a rapport building exercise and really help kind of strengthen that therapeutic alliance between the treatment team and the patient. And so asking open-ended and non-judgmental questions, listening actively, restating the patient's report to make sure that you understand, um, using clarification statements about the pain. So it sounds as though the pain is usually worse for you at night or with activity. And then demonstrating empathy and using statements to reflect feelings. So this must be very difficult for you. How have you been trying to manage it? Um, and then things to think about. If they're around other folks or other folks in their family have substance use disorders. Some clinicians use pill callbacks to see if folks are using their medications early, needing early refills. Um, and then sometimes um, it can be a warning sign if patients are specifically asking for only specific brand name medications, refusing to participate in any components of non-pharmacologic pain management strategies. So some pain assessment tools. The brief pain inventory is you're probably familiar with components of it. I find that most hospitals, either nursing or their clinicians, will have in their pain assessment will have elements of asking over a period of time, um, when has it been the worst, what has been relieving it, describing characters of it. Something that the brief pain inventory has that's kind of helpful is like different functional domains. So activity, sleep, job. So it really kind of gauges how it's impacting their life from a more functional element there. And so with chronic non-cancer pain and addiction, as we were saying, they frequently co-occur, um, share kind of patterns for exacerbation neurophysiologically. Both are dynamic with a physical and affective emotional component. Um, Treating one um, can support or conflict with treatment of another, and so um, what that means is sometimes if you have a patient who's admitted um, that's already on MAT, um, you can up titrate that medication sometimes for pain relief. So if a person is on 8 of Suboxone daily, you have some room to go up. Similarly with methadone. The thing there to consider is they might often need an adjunctive, um, something to either augment or considering a pain management service for like a local block, because there is often, I find, in the acute care setting, um, the perception that if a patient's on one of these MAT medications that they're receiving pain relief, when in reality they often have hyperalgesia, opioid-related hyperalgesia, where they're more sensitive to pain. And both are neurobiological conditions. They have evidence with disordered CNS function. Um, Clearly, consequences if untreated. And to this point, often have lower pain tolerance with hyperalgesia, and may, counterintuitively, we talked about a bit today with patients who are labeled as drug seeking. But this is often because their tolerance is much higher to opioids. So in the post-operative setting, for example, a standard pain regimen may not be sufficient for patients with opioids. Here's an algorithm for managing chronic pain. So up on the top, we have a diagnosis of chronic pain um, with functional impairment and some type of psychological comorbidity. And so on this pathway, we have the patient has active addiction, so you want to offer a form of MOUD or addiction treatment. Defer opioids and see how you can optimize non-pharm interventions. And if they're already on opioids, um, see if you can, wean them as much as possible and replace other adjuvant avenues. Um, and then if they're already in recovery, without medication, you want to again try your non-opioids as much as possible with other non-pharm pain treatments. And then if they're on agonist therapy, um, again, continue the agonist, but you may want to increase dose to optimize analgesia there. And so this is Institute for Clinical Systems Improvement, acute pain guidelines. So it's an opioid risk assessment tool. So these are some factors that kind of indicate that the person may be at risk for developing an opioid use disorder. Concomitant alcohol use, um, benzodiazepine or other drug use, um, clearance issues, delirium, dementia, and falls, psychiatric comorbidities, querying unusual patterns in the I-stop PMP, a history of sleep apnea or respiratory insufficiency, and safety issues at home, school, or operating motor vehicles. And so these are a couple of empirically validated tools. The SOAP-R screener and opioid assessment for patients with pain. This one has been found to be the most sensitive, but has many false positives. Opioid risk tool, which many folks are maybe familiar with. It's used in the primary care setting. Dire instrument, and then current opioid misuse measure. So once the patient's initiated on opioids, these three, the SOAP, ORT, and COMM are all on up to date, so you can pull those up if you want to use them in real time. And then the dire instruments on MDCalc, an app that some of you may be familiar with, but they're useful to kind of walk through. Like this is the COMM, the current opioid misuse measure. And so you ask, it's questions across domains of this with some functional impairment, memory impairment tasks. Have you ever had to go to someone else, so ask other folks to borrow medications, taking them differently than prescribed? Then it has some psychosocial domains. Taking more, okay, borrowed, yeah. So this is something, shortly after patients started on opioids, just to consider for risk for progression to use disorder. Then a graphic here, kind of in the total chronic pain population. There are the folks who meet criteria for a use disorder, but then there are folks who have a prescription who are misusing it. They're maybe taking more than directed, letting other folks use their medication. And as well, there's also what are called aberrant behaviors. We'll cover those in just a sec. But this is another spectrum of behaviors that may reflect misuse. And so opioids and the pain cycle, when it crosses to OUD, something that is usually indicative if some people get a very robust euphoric response. And I usually say to patients that, while opioids are effective on everyone, they take away pain from everybody. Some people have a genetic predisposition to have a really strong, robust, I usually say like fireworks going off in your brain, and some people are drawn to want to use it because of this intense euphoria they have. And then a negative reinforcer, meaning something that it's taking away, increasing the behavior, would be the reduction in pain. So you have these kind of this dual mechanism that leads people to want to use it more. When they're developing a tolerance, so diminished analgesia and euphoria, and then need to use more. A dose escalation to recapture efficacy, and then that kind of sets this cycle in motion of reinforcement. That once they're tolerating a certain dose, that's just usually to prevent them from going into withdrawal. If they want to get to efficacy, they're going to have to continuously escalate doses. And then if they experience opioid withdrawal or increased pain in the absence of opioid, you get concerned possible opioid use disorder. And then those criteria we talked about before, so consequences in use despite the harms, now a concern for addiction there. And so these aberrant medication taking behaviors, ones that are less likely to be predictive, complaining about needs for more medication. So this can just be titrating up to efficacy for pain control. Drug hoarding, and this means like if someone has like a dental procedure, if they keep their medication because they're concerned they may have pain in a week or so. Requesting specific pain medications, openly requiring similar medications from providers. Occasional unsanctioned dose escalation. So this is referring to, so sometimes I see folks who are on maintenance Suboxone who sustain an injury or have an outpatient procedure where they're given, say, Motrin or Tylenol. They'll say they took a few more than prescribed, but don't have it. It's not a habit. They're not taking it all the time, but for a small period of time, they had a dose escalation that wasn't necessarily discussed with their provider. Non-adherence to other recommendations for pain therapy. Whereas some of the aberrant behaviors that are more likely to predict addiction risk are the functional status, so deterioration in work obligations or social relationships, illegal activities, so selling, forging, or buying from non-medical sources, injection or snorting of the medications, multiple episodes of having lost scripts and needing early refills, resistance to trying any other type of therapies despite, say, maybe they have severe constipation on their opioid, yet they're not willing to try any other alternatives. Refusal or defensiveness with random drug screens, concurrent abuse of alcohol or other illicit drugs, and also going to multiple physicians or pharmacies. So when you're checking the PCP, seeing short supplies prescribed by multiple folks. So there's an addiction behaviors checklist that goes over these aberrant behaviors, and it goes over those behaviors that were on the previous slide. So if you want a specific tool, this is also part of tip 54. And so there can be a lot of different reasons for these behaviors. Inadequate pain control, one of them, progression of a disease, pain or discomfort related to withdrawal. We talked about the phenomenon of opioid-induced hyperalgesia. So now they've been on opioids for a period of time. They're sensitized to breakthrough pain, addiction or use disorder diagnosis. This is one sometimes I'll see when we were talking about unsanctioned dose escalation. I've seen patients who have a comorbid depression or anxiety, and sometimes they'll say that, say, Suboxone or methadone helps decrease that depression or anxiety, helps them feel numbed out from it. So that can sometimes be driving it. If they're undertreated, if their psychiatric illness is undertreated, it may motivate them to want to use more of their pain medication. Selling the medication or diverting it, and then misunderstanding of the direction, so the frequency and dose that is taking it. Another thing to throw out there, what are some best practices that you've seen or used for talking to patients about substance use? Anyone had like SBIRT acronym in their clinics or hospitals that ever come up for folks?
Yeah, Shane, there's an active expert program in a number of the different Northwell hospitals.
Oh, great. Are those in emergency settings or outpatient both?
They're both in ED settings and ambulatory settings, and they leverage a lot of like remote assessments, so they're available to kind of inpatient teams as well. So it's a great group of health coaches.
Great. So yeah, in working with you guys, the different hospitals, there often are screening, brief intervention, and referral to treatment. So expert programs. Some hospitals are introducing the concept of a patient navigator or peer counselors into their staff. And they're typically built around the model. These are just some principles of motivational interviewing. So it's an assessment technique and strategy that takes a non-judgmental stance. And so using open-ended questions that express concern about the behavior, it's important to kind of in the approach, it's like asking permission for education. Sometimes patients, when they're admitted into the hospital, they don't respond as well necessarily to the fear tactics they've often encountered or heard some of the risks. They want kind of a more patient-centered approach. They may not be ready or motivated for abstinence, but are interested maybe in harm reduction or taking the initial steps towards like a referral for a methadone program or a Suboxone induction. So examining their flexibility, what kind of priorities are most important to them? Are they interested in pain relief, or do they feel that they need the opioid? They're scared of the subjective experience of withdrawal. Approach as if they have a relative and not absolute contraindication to medications. This is going back to worrying about making the addiction worse and not wanting to give any opioids or any pain medications. And with that, kind of providing reassurance, setting limits in a compassionate frame. So kind of assessing and eliciting what is most important for the patient, and then kind of discussing with them what can be offered in your system within the parameters of treatment. If you're interested, we'll be sending these slides out. There's some practice guidelines from ASAM, and also the SAMHSA tips too are another good resource. And I'll hand it over to Noah and Adetayo about the survey and CME credits.
Thanks, Shane. So this survey is the same one that we've been presenting on the other lectures. So if you've already done a survey for our team, please do not complete this survey. But if you have not done a survey for us, we have a confidential survey that asks about your thoughts about how well situated your hospital is to address opioid use disorder in the inpatient setting. And on the next slide, I'll show you the QR codes that are specific to your hospital. The slide says it takes 25 minutes. It's really more like 15. And then if you could just go back for 1 second, Shane. When you're done, so the survey is anonymous, so we don't know who took the survey. The only way we'll know to compensate you is if you email us at this email address, hbotstudy@nyulangone.org. And that way we'll know to send you a gift card. So I know a lot of people took the survey last time. So if you didn't get your gift card, you can just email us and we'll send it to you. And again, this is the same survey that we've been presenting. So if you've already done a survey for our study, please do not complete this. Yeah, you can go forward, Shane, now. And so these are the QR codes, and then Adetayo is putting in the link also in the chat, the direct links. So if you'd rather not scan the QR and just click the link, you could do it from the chat. And I'll turn it over to Adetayo to give information about the CME credits.
Yes, I'll be posting links about the CME credit right now. Just so you know, please, if you haven't put your name and role as well in the chat, please could you help us do that as well? Thank you.
Yeah, you could keep that slide up, Shane.
Is there anything that people need to do for the CME credit?
Yes, Adetayo is going to post the link right now. And so you have to click that link and fill out the survey, the evaluation survey to claim your credit.
So it's a separate, so there's two surveys, our survey and then the CME survey.
Exactly, yes.
But it's so great to have the CME for these. So thanks again to our partners at Northwell for offering this. And we'll continue to offer CMEs for all of the upcoming lectures. Our next one is in 2 weeks, and it is going to cover the management of acute pain and withdrawal, opioid withdrawal, again with a focus on hospital settings. So should be another really useful presentation. Hope to see you there. Any closing business? We'll keep the links up for a while too.
Just one final closing thing about the CME as well. Please, if you can, try and get it done before the next 24 hours. The links will expire by tomorrow morning.
Okay, we'll keep the links up for another minute or two until we close out the webinar, but we'll just take this occasion to say thanks again for joining, and thank you, Shane, for leading us through the material today.